I am a clinician scientist based at the University of the Witwatersrand in Johannesburg, where I'm also a professor of global health and infectious diseases. And I'm delighted that you're able to join us really for the symposium that's going to dive into the kind of advances we've had in HIV prevention, particularly with respect to long-acting agents and some of the experiences and challenges with implementation, particularly amongst adolescents. So we have a great panel lined up. I'm sure they're going to really keep you entertained and stimulated for the next hour. But before we introduce them, I wanted to hand over to my co-moderator for him to introduce himself.
Thank you very much. Hi everyone, it's great to see you all here. My name is Benjamin Bamerton. I'm a research fellow at the Conf Institute in Sydney. And my work focuses primarily on HIV prevention in gay, bisexual and transgender women. And of course, like a lot of us in this room, most of my work these days is around PrEP, and particularly looking into the future of long-acting PrEP. So again, I'll just reiterate, we're really excited about this session, and I'll pass back to Sinead to get going.
Thanks very much. So the first presentation will be given by Dr. Albert Liu, and he is the Clinical Research Director of Bridge HIV within the San Francisco Department of Public Health. And he's also a Clinical Professor of Medicine at UCSF. His interests, not surprisingly, focus on novel PrEP agents and how best to implement PrEP in real-world settings. And he is going to speak to us about updates on long-acting prevention technologies and really give us an overview and an introduction to the rest of the session. So over to you, Al, and thanks very much.
Great, thanks so much, Jade, for the introduction. So it's a really exciting time in HIV prevention, and we have a number of long-acting options on the horizon. And we actually have two agents that are already approved in a number of countries, and that includes CAB-LA and HERONEWS. And then there are a number of other ones that are in the experimental phases of the pipeline, and we'll talk about lenacapavir, MK-8527, implants, and broadly neutralizing antibodies. I'd like to start with this great slide from AVAC, which highlights that it's not only important to consider clinical considerations such as safety and efficacy, but we also need to think about policy, program, and personal considerations. So for example, someone might really like a long-acting product because there's low user burden and there's less stigma, but it actually may increase the strain on the system. There might be more requirements for provider training. It might increase costs. So it's never just about the product. We have to think about the broader context, the broader program, as well as the people using the product. So starting with long-acting cabotegravir, it's an intramuscular injection given every 2 months after a 1-month loading dose. There are two landmark studies, HPTN-083, which is in cisgender men and transgender women, and HPTN-084 in cisgender women in Africa. Both trials showed superiority of CAB-LA with a 66 to 88% reduction in HIV incidence compared with daily oral TDF-FTC. And I just want to highlight a few studies, recent studies of CAB-LA. Meredith Clement at this conference is presenting data showing really high preference for CAB-LA over TDF-FTC in the open label extension of HPTN-083. We also have emerging data at this conference really supporting the use of CAB-LA during pregnancy. And there's also an ultra long-acting formulation of CAB that can be dosed every 4 months, and that's moving forward in clinical trials. I also want to briefly touch on the LEVI, or the long-acting early viral inhibition syndrome. So what we're seeing is in early infection can look really different in the setting of CAB-LA, where the viral loads are low, antibody expression can be delayed, and it can be really hard to make a diagnosis. And I want to point people to an article in the New England Journal that is coming out soon by Rafi Lampowitz on the Levi syndrome. CAB-LA was approved in the US in December 2021, and as of last month, there's 19 regulatory approvals for CAB-LA, and a number are pending and planned. And however, rollout has been relatively slow, and in Q1 of 2024, there are about 12,000 CAB-LA initiations, and mostly occurring in the US. So moving on next to lenacapavir, this is a highly potent small molecule HIV capsid inhibitor. It's given subcutaneously as an injection in the abdomen, and it's actually approved for HIV treatment for multi-drug resistant HIV, and is under study for pre-exposure prophylaxis. And so these are the purpose prevention studies. Purpose 1, the largest one, is enrolled over 5,000 cisgender adolescent girls and young women in South Africa and Uganda. Purpose 2 enrolled cisgender men who have sex with men, trans women and men, and gender non-binary individuals. Purpose 3 and 4 are smaller studies in US cisgender women and people who inject drugs. And finally, Purpose 5 is just getting off the ground in France and the UK. And I think most people have heard the groundbreaking news from Purpose 1, which showed 100% complete efficacy of lenacapavir in cisgender women. And the Independent Data Monitoring Committee recommended that the blinded phase of the study be stopped and that all participants be offered open-label lenacapavir. In the study, participants were randomized 2 to 1 to lenacapavir, oral Descovy, or oral Truvada. And you can see HIV incidence was 0 in the lenacapavir arm, 1.69 in the Truvada arm, and 2.02 in the Descovy arm. They also looked at background HIV incidence, and it was 2.41 per 100 person years, and that was based on recency testing during screening. And we're all looking forward to hearing the full results of Purpose 1 tomorrow by Lydia Becker during the co-chair's choice session. So next, I want to talk about the Dipivirine vaginal ring. This is an exciting product that's women-initiated and discreet. There are 2 large phase 3 trials, the ASPIRE study conducted by the MTN, and the RING study conducted through the International Partnership for Microbicides. Both studies found that the ring was safe and well tolerated and had about a 30% reduction in HIV incidence. And in the open label phases of the study, HOPE and DREAM, they saw high levels of uptake and use of the ring and about a 40 to 60% reduction in HIV incidence. And in the ASPIRE study, they actually did some exploratory analyses conducted by Elizabeth Brown, which estimated 75 to 91% HIV reduction when there was greater than 4 milligram Dipivirine release from the ring, which basically indicates really high level or daily use of the ring. We also have safety and acceptability data of the Dipivirine ring in pregnancy as well as breastfeeding, which is great. And the WHO has recommended the ring for at-risk women as well as it has been approved in over 10 African countries. There's also additional research on extended duration rings, 90-day rings, which could help lower costs, and multi-purpose technology rings, which can help with HIV prevention as well as contraception. So the next long-acting agent I'm going to talk about is MK8527. This is a new NRTTI, or nucleoside reverse transcriptase translocation inhibitor. And islatravir, which is in the same class, people may have heard, caused a reduction in CD4 as well as lymphocyte counts. And it's actually been discontinued from further evaluation for prevention. MK8527 is a similar but related molecule and not thought to cause the lymphocyte reductions. And in 2 phase 1 studies, it was found to be well tolerated and achieved target concentrations with long half-lives that would support weekly or longer dosing. And so there's a phase 2 study now of monthly dosing of MK8527, it's an oral pill monthly, and that's fully enrolled, and we hope to see results in the next year. Next, moving on to the HIV implant. This was data presented at CROI by Gangai and colleagues of a TAF silicone implant in the Caprisa 018 study. This was in South African women. And on the left side is the PK data. You can see that for tenofovir diphosphate levels, that they didn't quite reach target concentrations, which are in the dotted line. And this was either with 1 or 2 implants. The safety data is on the right, and you can see that implant site reactions were quite frequent. Most of them were mild or moderate in severity, but about a third of implants had to be removed early due to tolerability issues. And so they raised that we need to both increase drug release to get better levels, but also reduce implant site reactions, so a little bit of a challenge. There's also this thing called an in situ forming implant, or ISFI, and data at CROI also showed or was presented on an ultra-long-acting dolutegravir implant implant in mice. And the way this works is that there's a combination of solvent, polymer, and dolutegravir that are combined in the syringe and injected. It forms this in situ implant, which can be biodegradable and removable. And they showed that this was safe and achieved target concentrations for over 300 days. So finally, I'd like to talk about broadly neutralizing antibodies. The AMP trials were proof of concept trials led by Larry Corey and Mike Cohen, which demonstrated that the monoclonal antibody VRC01 was safe, acceptable, tolerable, and had good adherence. And while the trial overall did not show protection, we did see a high efficacy in the subset of individuals who had highly sensitive virus. And so while a single antibody is unlikely to have sufficient broad enough coverage for global viruses, if you combine these broadly neutralizing antibodies into a triple cocktail, we think that we can increase coverage up to greater than 90%. And so on the left, you can see an example of a triple cocktail that targets 3 different sites on HIV, the V3 glycan by an antibody PGD121, the V2 apex by an antibody PGD1400, and finally the CD4 binding site by VRC07. Now, there's versions of the antibodies with the LS mutation in the FC portion of the antibody, which really extends the half-life and allows every 6-month dosing. And I want to point people to 2 posters that are presented of phase 1 data from these antibodies, and ultimately they're moving into phase 2 studies called Combo AMP. So just want to end with a few key takeaways. There's several long-acting prevention technologies. Some are available already, and others are in the pipeline, and they can really expand our options for PrEP choice. However, they are not a panacea. Some people are not going to want long-acting products, so we need to look at other types of PrEP options, including short-acting, on-demand products. And as we said in the AVAC slide, we need to consider policy and program context as well as end users. And finally, cost, supply, accessibility, and creating demand are all critical issues that we're going to address and will be talked about by some of the other speakers. And I just wanted to end with a shout out to the artist around Domingo Bassos, who I actually had the pleasure to work with as part of the HIV Sciences art program. He created these beautiful paper cut artworks that actually was to represent this session on long-acting prevention. And he says, in these pieces, flowers symbolize expansion, sexuality, pleasure, reflecting openness to others, the willingness to expand beyond oneself, and the desire to connect. And I think that really highlights why we're doing this work. So I want to encourage people to check out this exhibit. It's here all week at the Brain Lab. It's just 3 minutes away. It's a great exhibit. Just want to end with acknowledgements on everyone who helped put this talk together. Thank you so much.
Thank you so much, Al, for that wonderful comprehensive overview. I now want to introduce Thiago Torres. He's a researcher and professor in public health, focusing on sexual and gender minorities and HIV treatment or prevention at the Institute Fiocruz in Brazil. And he is going to talk to us about demonstration and implementation studies of long-acting care.
Thank you so much for the introduction. Sorry for my voice. So I had the mission to put together the data that we have about demonstration and implementation studies. So I based my presentation on the dashboard created by AVAC and on the initial results presented at the last IAS and CROI conferences. So according to the AVAC dashboard, there are 45 ongoing or planned implementation studies using CAB-LA globally at this moment. Most of these studies are conducted in Eastern and Southern Africa, followed by North America. Studies are being conducted in several countries from different regions in the globe. Here we can see that most of the studies are enrolling cis women, but an important number of them are also enrolling key populations. 30% of the studies are planning to include more than 1,000 persons, and 60% less than 1,000 persons. So here, according to AVAC, there is one completed study, 30 ongoing studies, and 11 are planned to start. So I'm briefly talking about some studies conducted in Africa. The first one is the SEARCH study. So the SEARCH study is evaluating a dynamic choice HIV prevention intervention, including KBLA as a PrEP option. So they found in this study a 56% difference in biometrical coverage in the intervention arm compared to the standard of care arm. And the standard of care did not include KBLA as an option. 56% chose KBLA among the PrEP options, and 43% are using KBLA were PrEP naive. And in this study, there were no seroconversions in the intervention arm compared to 7 in the standard of care arm. Other two examples of studies conducted in Africa is one evaluating PrEP choice among transgender people in Uganda. And the mobile men study is focusing on men who are mobile for work in Uganda and South Africa. Another study is the Catalytic, who is providing local community engagement and PrEP choice for 11,000 people in 28 sites in 5 countries in Africa. The study supported by MSF is evaluating differentiated delivery model of including CAB-LA as PrEP option among different key populations in 4 countries. In Malawi, 3 studies are ongoing, including the path to scale for CAB that will include 10,000 persons in 36 sites. In Zimbabwe, 1 study is evaluating PrEP choice among cis women, and 1 study in Botswana is evaluating adherence and effectiveness of CAB immediately postpartum. In South Africa, the FAST PrEP is evaluating preferences by offering decentralized PrEP service through facility mobile clinic community model among 25,000 people. And the Let's Talk study will include 26,000 young persons in 40 clusters from a rural area and will evaluate social mobilization by peer navigators into community-based sexual health and HIV clinics. Now I'm going to talk a little about the studies from the United States and some results presented at CROI this year. So this study conducted in DC observed high initial retention rates, but a notable number of missed windows. Insurance medication coverage was considered a significant barrier for CAB implementation. The OPERA cohort included 101 clinics in 23 states in the US. Among 506 initiations in CAB, 11% did not return for the second injection. And among those who had at least 2 injections, 69% had all injections on time. In a study from San Diego, discontinuation was higher among those of younger age with no medication assistance program and those who missed injection. In San Francisco, KBLA delivery using a low barrier comprehensive care model provided high rates of retention and no seroconversion in a population under high social vulnerability. In the PILAR study, 220 cis-MSM and trans men in 17 US sites were randomized to routine vest dynamic implementation. This dynamic implementation includes telehealth strategies. And a large proportion of participants who were interviewed were satisfied and found telehealth delivery to be both easy and helpful for PrEP delivery. And the Ebony study is evaluating CAB delivery among Black, cis, and trans women in the US. So providers in the study reported high levels of appropriateness of KBLA for Black women. In Europe, 3 studies are being conducted among MSM. 2 are ongoing, 1 in Belgium and another one in Ukraine, and 1 in France is planned to start soon. Now Latin America. So in Latin America we have 2 studies being conducted, both in Brazil. So the first one is a PrEP CAB Brazil study, which aims to generate critical evidence to inform national policies and program implementers about optimizing same-day delivery of CAB for sexual and gender minorities within the public health PrEP services. So during the formative phase, the study conducted process mapping, and the process mapping main challenges for same-day CAB-LA delivery were the duration of visits due to long time of laboratory and HIV counseling steps. Community mobilization permitted the development of more inclusive and culturally appropriate HIV prevention materials and interventions. And in the focus group discussions, WhatsApp messaging for appointment reminder and mHealth tool for PrEP choice were highly acceptable. The second study in Brazil is the study PrEP 1519 Choices, which will also provide information for the national policies, and it's being conducted in 3 Brazilian cities, recruiting sexual and gender minorities aged 15 to 19 years. And 10 other studies, according to AVAC dashboard, are planned among diverse population and regions, including studies in Australia, Thailand, and Vietnam. So in conclusion, early results show high acceptability of CAB-LA in multiple settings and populations. PrEP choice and person-centered decision-making can increase overall prevention coverage and effectiveness. Demand creation and community involvement are needed to increase CAB-LA awareness and uptake. Different PrEP delivery models such as mobile units, pharmacies, and home delivery are being evaluated in the studies. And most important, access to CAB-LA should be guaranteed to all populations in need, even after the end of these studies, especially in the Global South. Thanks to all my colleagues who collaborated for this presentation. Thank you, obrigado, danke schön.
Thanks very much, Jeremy. That was great. Really exciting to see such a huge amount of research happening across the world. So let's move on to the next presentation, which will be on long-acting prevention and adolescence. And I'd like to introduce Linda Stranik-Chimanda, who's a pediatrician from Zimbabwe with over 20 years of experience delivering HIV services to women, children, and adolescents at the primary care level. And she's run clinical trials of new agents for prevention and treatment in complex populations. And she's co-chair of the adolescent sub-study of long-acting HIV and PrEP. Thanks, Linda.
Thank you, Ben. Hi, everyone. It's an absolute pleasure to be here to share some thoughts and insights specific to adolescents with HIV prevention and long-acting methods. So, why are we talking about adolescents? And some people need to be reminded that HIV in adolescence is a public health concern. In 2022, 140,000 adolescents aged 10 to 19 years acquired HIV, and the numbers sadly are not very different from the recently released estimates from 2023. About 10% of all people globally acquiring HIV each year are aged between 10 and 19 years. So adolescent HIV is an issue of public concern and it needs to be addressed. Interventions must be tailored specifically to the different nature and dynamic of the HIV epidemic across the different regions in the world. In 2022, of all adolescents acquiring HIV, 4 in 5 of those were girls. 2 in 3 lived in Eastern and Southern or Western Central Africa. And within that region, the highest number of people acquiring HIV were adolescent girls and young women aged 15 to 24 years, specifically living in Southern Africa. However, in East Asia and the Pacific, more boys acquire HIV each year than girls aged 10 to 19. So our interventions need to take this into account and be tailored specifically to the different populations in the different regions. I don't think this is news to those in the audience today, but it's important to remind ourselves of that. So, specifically to adolescents, long-acting projects could be well suited to their particular needs. A long-acting regimen is obviously simplified when compared to a daily regimen that often adolescents might have challenges with in terms of persisting with daily adherence. The infrequent frequency of dosing in long-acting regimens is specifically appreciated by our younger people, and they appreciate the increased privacy that a long-acting regimen offers. For injectable long-acting PrEP, that again is directly administered, so the administration is guaranteed. You're sure that that product has been taken. And the long-acting products carry the potential for multi-purpose prevention. I'm especially encouraged to see the developments. Can we be protecting against other STIs as well as HIV and pregnancy? So adolescent lives matter. We need to pay attention to this population. On the research side, the involvement of adolescents supported the product licensure in that age group. We aimed for simultaneous licensure in adults and adolescents. And the research groups that were working with the first long-acting products that came out were able to pretty much accomplish that. For the long-acting dipivirine vaginal ring and the long-acting injectable cabotegravir that you heard about in the previous presentations. When we conducted those trials, we found that there were no age-specific concerns or requirements in terms of safety and dosing. So we are able to use these products in the younger age group, and it is safe to do so without dose modification. But that's not the only aspect of research that we studied. And for the adolescent populations, it was vital to look at the feasibility, the acceptability, and the tolerance. So in the HPTN 08401 trial, which looked at those aspects in the long-acting injectable cabotegravir, that product was found to be tolerated very well by the young people. No injections were discontinued due to intolerance. And more than 98% of those doses were administered exactly on time. So that was a tremendous success for this product. The adolescents were also very clearly able to articulate exactly what they appreciated about the long-acting product. They were able to tell us why they liked using it, as well as to bring forward any concerns they had. We were worried that they might not tolerate the injections. We were always told about needle phobia and fear, and that was always a consideration. That would this deter them from coming forward for a long-acting injectable product? Well, that didn't turn out to be the case, and almost all of them opted to continue receiving the long-acting injectable cabotegravir PrEP at the end of this trial in the open-label extension product. So that was for the cabotegravir injection. For the dipivirine vaginal ring, a different study was done, and these adolescents were able to experience using the ring and then the daily oral PrEP, or had been randomized to start with daily oral and then move on to the vaginal ring. So they had direct experience of both methods, and then were given a choice. And they were able to make that choice and select the method that they found better suited to their specific individual needs. And during the choice period, 67% of those adolescents chose the long-acting method, which in that trial happened to be the ring. So similar outcomes are anticipated for the newer long-acting technologies. And I'm sure you're all awaiting tomorrow's presentation about the lenacapavir results. And to note, for that trial, phase 3 trial, they were able to engage and involve adolescents right away at the same time as the adults were enrolled. So look out for that tomorrow. However, product licensure does not equal access. And when it comes to adolescence, I think we're all very aware that we have to work very hard. There's a lot more we need to do to address the stigma around adolescent sexuality and disclosure to parents, as well as overcoming medical mistrust and ensuring that young people have access to high-quality, respectful health services. And without that, the long-acting products in the clinic will not reach the people who need them. Also, having options, having different products in the clinic does not equal choice, because the ability for an individual to select from an array of products require those products to be available, but also accessible and affordable. Having more products in the clinic actually adds complexity to choice. And we're always told that adolescents require additional support in navigating decisions. And this is what we find with the young people that we've enrolled in our trial. However, they are able to demonstrate agency when given the information that they need and want, presented to them in a way they are able to relate to, and in an environment where they feel comfortable to come forward with the myriad of questions and issues that they want to tell you about. So once that has been taken care of, they are able to make a choice. When parents are engaged, in our experience, they have been very supportive of their child's use of these products. And we're learning more about how to engage communities, how to prepare them for the long-acting methods in adolescence. There are a number of groups working on this aspect of decisional support, and that might be specifically helpful to support adolescents navigate this choice of multiple options that are available in the clinic. And in the female population, we also need to consider the contraception choice, which often goes together in those that choose to contracept. One example of a decisional support tool is the MyPrep tool that has been piloted in South Africa and is being expanded to other groups. So, in short, adolescents need a tailored health service in order for them to benefit truly from long-acting prevention technologies. That health service needs to be accessible, integrated, status neutral and non-judgmental in order to protect them against HIV and other sexual reproductive health matters. Adolescents are unique, but they are able to come forward and tell you what they want and need when the environment and the health providers are able to make them feel safe and give them the information they need in a way they can relate to. So I'd like to close by first off acknowledging all the courageous adolescents and their families who've participated in these research trials that you've heard about, as well as all the research groups and the others, the teams that are involved in coming up with this work. Thank you.
Thanks very much, Linda. That was a really great presentation. It's always pleasing to me to see that, along with the really important population of adolescent girls in sub-Saharan Africa, that there's also young boys and men in Asia, particularly, where they are acquiring HIV. So it was great to see that acknowledged. Our next speaker I'd like to introduce is Camille Romero, and she is the Research Program Manager for the Access to Medicine Index Program at the Access to Medicine Foundation, leading the dedicated research team there. And so Camille has a Doctorate of Pharmacy from France and a Master of Public Health from the US, where she focused on the area of global health and pharmaceuticals. And Camille will be talking about galvanizing new product access for low and middle income countries. Thank you.
Good afternoon, everybody. So, this afternoon I'm going to talk to you after a really interesting presentation on the different options for PrEP for long-acting PrEP that we have available, into how to ensure access, and specifically the role of the pharmaceutical industry. So a little bit about us, for those of you that don't know us. We are a research-based organization based in the Netherlands. Our mandate is to mobilize essential health and healthcare companies to improve access to medicine in low-income countries. Important to note that we are completely independent. We do not receive any funding from the pharmaceutical sectors or any other healthcare company. And a list of our funders at the bottom of this slide. Here in this slide you see like the country in a scope of research. So we look at what pharmaceutical industry is doing in those countries to improve access. Important to note also that we look at 81 diseases and pathogens. Of course that includes HIV/AIDS, but we also look at access to medication, for example, antibiotics for AMR, and we also look at medication for LCDs, etc. How do we drive change? So we have a unique approach and a unique model of change. We first try to build multi-stakeholder consensus where possible, and the expectation of the role of responsibility of pharmaceutical industry to improve access to those key products. Then we collect data both from the public domain but also directly from the companies. And we publish reports, we identify where there is gap in their practice, and we identify some opportunities that then we are trying to mobilize them on. We also track progress. We've been around for like now almost 20 years, so we've been evaluating the company for 20 years. And it actually started by looking specifically at HIV and AIDS. We also identify what we call best practices, so they are sort of gold standard. I don't really like using that term, but gold standard for those practices from the pharmaceutical industry. And we really push them forward for other actors, like other companies, to adopt them. And then with those best practices, with those opportunities, we then engage a range of stakeholders on those questions. For example, we will engage investors. They are like the majority shareholder in the company, and they have a strong voice to influence them. So we share the results with them when they go and engage with company. We engage also, of course, elementary stakeholders, governments, but also high-income country governments, where the majority of the largest pharmaceutical companies are implemented. So we have a multitude of programs, and for the purpose of today, I'm going to focus on the top two, which is like the R&D-based pharmaceutical company programs that I lead at the foundation, and the generic and biosimilar medicine manufacturers. And just to give you an idea of which company we are evaluating, for example, in my program we have companies like GSK, Gilead, BMS, Janssen, etc. And in the generic program, we look, for example, at companies like Ciplas and Pharma or Bindo. So here are two products that have already been talked about in the previous presentation that are in the scope of research and where we look at the action of the companies to improve access. So Cabelane, which of course the originator is Viv Healthcare, majority owned by GSK. And one product that's still in development for PrEP, lenacapavir, the originator is Gilead. So we've developed what we call an access to medicine index roadmap to access that lists like some of the key actions that we recommend pharmaceutical companies to take to improve access in those countries. And it goes from investing in priority R&D to develop those products where there's gaps, fight for registration as broadly as possible in NMSCs, implement an equitable pricing strategy, licensing, and finally, where possible, participate in some capacity building initiatives. So a few examples I'm going to zoom in of what we saw across the year. So in terms of conduct R&D and priority gaps, we also asked companies during the development phase to plan for access while the projects are still in the pipeline. We really believe that if they plan for access closer to registration, it's too late. We really want people in low and middle income countries to have access to those products as soon as possible after first global introduction. So here it's an example of an opportunity that we identified in the 2022 index for Gilead, where we saw that their access plan, there was some gap, and we really got an opportunity for them to include additional components such as plan for registration, think already about your equitable pricing strategy while your project is in development. And also, that won't be news for a lot of you in the room, but think about non-exclusive voluntary licensing in those countries. Clinical trial diversity, I'm going to pass on this one because the other speakers have addressed it, but this is also something we look at when assessing the pipeline of this company. So, hot topic, non-exclusive voluntary licensing to enable generic manufacturing. So one of our recommendations to galvanize access is to license product either through the medicine patent pool or like work directly with the generic company on access-friendly licensing term. So here an example for Cabele. As we all know, it received like approval for PrEP in 2021 in the US. And the company issued a license with MPP in 2022. As of today, 3 generic manufacturers have taken on the license, so Aurobindo, Cipla, and Viatris. But on the other side, while we give recommendation to the large manufacturer, we also look at the generic manufacturers, and we recommend them when they take on those license, go on and register as broadly as possible within the scope of the license. And finally, I wanted to say also, because I know there's a lot of talk about medicine price, and especially the Cabele price. Pricing strategy is only one part of the equation in product delivery. The strategy needs to be comprehensive, both for the company and the people who are at risk of HIV, to ensure that the products have maximum reach across the income pyramid. So that includes, as I said, pricing strategy. Companies really need to look at the unique population ability to pay, both like setting different strategies depending on the country, but also within country. Look at the people going to the private sector, public sector, do they have a copay? They really need to consider all those factors. Of course, licensing, as I mentioned in the previous slide, but with all those strategies also, if you don't look at ensuring continuous supply, if you don't look at a strong supply chain, then there's no way the products are going to reach the last mile and the patient. So companies also have a responsibility, of course with partners, but they need to look at that. And finally, in terms of capacity building, where appropriate and where feasible, if they have the expertise or the financial support, we also look at the initiative they engage in. And I wanted to conclude this presentation by 3 next steps. It is key that everyone involved in the HIV prevention have a clear understanding of the role and responsibility of company. It is also key for company to implement continuous efforts. It needs to start from clinical development, as I say. Again, close to registration is too late. However, once it's globally introduced, they really need also to push forward. And finally, everyone involved need to put conditions in place for timely access. Thank you.
So we're very fortunate actually now that we have about 15 minutes for questions from the audience, and I'll also just remind the viewers online that that's open to you as well. I've got the iPad here, so I can pass on those questions to our speakers. So if anyone would like to ask a question, please step up to the microphones now.
So maybe while we're waiting for people to come up to the mic, one of the things that struck me through all your presentations, I'm not sure that it was deliberate, was that there was a very strong theme around it's not enough to have products, you have to have access. So maybe I can ask each of you in turn from your perspective to reflect a little bit on kind of what have we learned about ensuring access. We started off with oral PrEP, we've had the ring, we've got injectable CAB, we're anticipating lenacapavir and many of the other products that Lou and Al mentioned. So from your perspective, what are the things that we could learn from or do to kind of make sure that we accelerate access going forward? And also, what are the evidence gaps that we need to be sure to be addressing in order to kind of really accelerate access broadly for populations? And maybe I can start with you, Linda. Unless Camille, you want to go first?
Yeah, for me, it's key that it needs to be a multi-stakeholder partnership. Companies really need to